So there are so many ways to learn about cancer. This course is not about tumor biology or tumor mutations, although you might hear a lot about it. This is about cancer care on the ground and how we take care of patients, how they present to us, how we think about them, how we think about how the care is going to be integrated into their lives, and then something about the genetic mutations and the varieties in chemotherapy. And this is cancer care as I know it as a clinician. Now, how many of you in this room are in a PhD program or have a PhD? Right. Okay. How many don't? Okay, very good. Okay, so how many of you are in your initial level of training, undergraduate or in your master's or PhD programs? Okay, quite a few. All right. How many of you are postdoctoral fellows? Good. Faculty? Couple. Faculty. Excellent. Okay. How many of you are not in training or teaching? You're in nonprofits or industries or OTD. Very good. Did I miss anybody? No? Anybody? Okay. So tomorrow I'm going to be giving you a little overview on who you are, because I think it's really important. You need to get to know the people who are sitting at the table with you. You need to find out what each other is doing. You need to have an active and curious mind while you're here. Nothing will be spoon-fed to you in terms of like engaging you. You need to be interested in this course. And I certainly hope we've worked very hard on making these talks very interactive. So I want you to engage, to have an active and curious mind. And if you don't find a person you want to talk with here today, or you can't find them, or you get busy, let me know, because I want to make sure that I can connect you. That's what I'm really good at. I'm really good at connecting people. This course is about you guys, and about our speakers, and about what's going to happen in the future. I will only operate on a few thousand people in my lifetime. But by having an influence through a course like this, you guys can go out and do something to help with cancer care in the future. Now, there are going to be things that you hear during the course that are going to upset you, or shock you, or surprise you, or make you really depressed, or make you really glad. You might have questions about how we do something and why we choose to do it that way. I encourage them, but wait until the end of the talk. So we have our talks tailored so they're relatively short compared to the time. So there's plenty of room at the end for you guys to ask questions, and I encourage you to do so. And if you don't, I'll be forced to ask questions myself, which I have no problem doing. Cancer itself, right, doesn't come down from outer space. I don't believe that anyway. Doesn't come from, could be UV radiation. Technically, that's outer space. But cancer comes from you. Cancer is an inadequately controlled division and multiplication of cells that can infiltrate adjacent tissues and often forms distant secondary lesions. What does that mean? What it means is, any of you take Latin? Oh my God, that's depressing. Okay, I had to take Latin. So the word neoplasm means new growth, neoplasm, new growth. It doesn't mean cancer. Cancer comes from a Greek word, which actually means crab, because it grabs hold, okay? So when I see this statement, it's telling you that not all things that grow in the body are cancer. Not all things that grow, some can harm you because they grow in bad places, but they can't spread like cancer does. Now, the other thing that we know about cancer is it's ancient. We've known about it forever. Even bony lesions in dinosaurs, Egyptian mummies have been found to have all kinds of interesting tumors. The earliest recorded surgical intervention was for breast cancer based on the Edwin Smith papyrus. We have Jane Mendez coming to talk with us about that tomorrow. And in fact, they've been trying to manage cancer of the breast for years with all forms of cauterization and so on and so forth. If you can imagine, even in the 1600s, there was an attempt to surgically intervene for breast cancer. We're going to talk about why that wasn't such a great idea and what we do so much better now. And of course, along with the rise of treatments for cancer have come a better understanding of what underlies disease in humans to begin with. So you know that there was the concept of the different humors, right? Black bile, phlegm, those sort of things. Cancer being contagious, the idea behind that. even the idea that there's a balance between hot and cold, and you have to balance the foods that you eat. Even nowadays, complementary and integrative medicine for treatment of cancer, it's a big, big business. Complementary and alternative medicine, $34 billion out of pocket alone. And when you think about it, it might sound a little out there, but in fact, many of the common chemotherapy treatments we know come from natural elements like Taxol from the yew tree. We also know that 1/3 of all Americans will probably die of cancer. Certainly the rest of them may die with cancer. You might have heard recently about prostate cancer. Many of the men over age 70 on autopsy are found to have a focus of prostate cancer, but that doesn't become a significant thing that needs surgical intervention. Why not? So what makes the difference between why some people develop it, some don't? Some develop it when they're 15, some develop it when they're 80. It comes in all different types of presentations. Some people are treated better. Some things we screen for. Why do we do mammography? Why don't we do chest x-rays in everyone who has lung disease? As Avi Spira is going to talk with you about tomorrow, it's because we know that we have good treatment early for some things and we don't for others. And the other thing you have to remember is I think of this now, because I'm getting a little older, right, 42, I'm thinking about this on a systems perspective. I think about, well, where does my information about cancer come from? How do I know to give the NIGRO protocol for anal cancer? It's actually based on 5 patients, and that forms the basis for how we treat patients with anal cancer. And where does the funding come from to do research? Some comes from industry, other comes from the National Institutes of Health, the Department of Defense, actually, the American Cancer Society, who's going to have a table here today. Now, not all of my slides are intended to be read top to bottom, okay? So I'm trying to give you you're here to hear my perspective. You can open a book and read this, okay? I'm trying to give you my personal perspective on how I take care of patients, how I think about patients with cancer. We're going to talk about some larger concept things to start with, and then we're going to move to what I actually do for a living. So scientific discoveries in cancer treatment go hand in hand and have for years. From the first, we didn't really even know that there were cells in the body until microscopy came, right? The viral tumorigenesis with Doug Fowler, who does research in that area, the idea that viruses are involved with the formation of cancer. Even people who were almost uninvolved with cancer care, like Percival Pott, noticed that there were a lot of chimney sweeps with scrotal cancer, one of the first epidemiologic studies. And we actually have a couple of biostatisticians here in the office, here in the audience today. You're not all engineers, by the way, so you come from a large variety of backgrounds. And then the whole concept of carcinogenesis, that there are things in the air, things in our genes, things in the food that we drink, things in nature that have an effect on whether we're more or less likely to form different sorts or types of cancer. So everyone lives embedded in a framework. Our patients come to us not as just an individual. They come with a history, with a sense of their self, from a society that either supports screening or doesn't support screening. Families that are supportive of care, not supportive of care, don't understand care. Most of my patients are ethnically diverse. It's unusual for me to go into clinic, and out of 20 patients, usually 15 don't speak English. Everything from Cameroonian Hill dialect to Cantonese to just about every language you can imagine. I happen to love that because I like a good challenge. Most of my patients work, if not one job, maybe 2, have families to support. They think about their future. All of this comes in the door when they come to talk with me. Everything that you say to a patient has an impact. So when I have a patient come in and I tell them that they have cancer and maybe they have a genetic mutation, the first thing they think about is, what about my kids? Did I give a bad gene to my children? You can't just give information to a patient in a vacuum. So for example, I happen to do high throughput screening. In one of my projects with Kathy Clapridge, we do high throughput screening for thyroid cancer for diagnosis. So that means I could get very rapid turnover. You come in the door to see me, maybe I do a biopsy of your thyroid gland under ultrasound, I could tell you some of your genetic defects within a few hours. But what a huge change in your mind between coming in with a nodule and then going home and thinking you have genes that are going to permanently affect your family. Maybe fast turnover in genetic markers isn't good without having a genetic counselor to sit down with patients to talk through the repercussions of what you're talking about. So as you guys hear what we're talking about, guys and gals, people, hear what we're talking about over the next couple of days, think about some of this. Think about the setting in which your technology or approach or interest comes from, whether it's really going to benefit patients, how you can make sure that it's going to be adopted, because you don't want to develop something that nobody's going to pick up. Patients' cancer treatment is embedded in a framework. You see the table over there, that's Boston Medical Center, Boston University. I work at both, Boston University, Boston Medical Center. I see patients, I'm on the faculty here. And when we treat patients, you know, we need to get paid for our treatment of patients. We treat a lot of patients who come from economically disadvantaged backgrounds, ethnically mixed. It's a great area to be doing some very interesting research into racial and economic disparities in patients. I've actually invited Chris Andry this afternoon to come and talk with you about some of the unique things that we have here. You need to think about these things when you go back to your own institution. Oh, that's really interesting. I wonder what the racial mix at the hospital is. If I'm doing research and I'm getting specimens from the biorepository, am I getting patients from a variety of backgrounds? Because as you all well know, when you check off, you know, what racial category you come from nowadays, right? Are we all just one? Very few of us are one background. We're really starting to mix in terms of our ethnic history. So we talk in terms of migration. We talk about, for example, if you need a bone marrow transplant, certain racial backgrounds, very difficult to get HLA matches to get a good bone marrow match for yourself, or even a kidney match for yourself. So we've expanded some of what we do to be able to do donations, for example. So when a patient comes in for cancer treatment, it's embedded in a whole framework. The hospital doesn't just arise de novo and suddenly provide care. There's all sorts of things that go into it. We have tumor registries. We're fortunate to have a tumor bank here. We have chaplain services, which have to come from a wide variety of backgrounds. All kinds of support groups and systems, because prostate cancer in a Haitian male may mean something very different from prostate cancer in a Caucasian male in terms of acceptability of surgical intervention. We have wonderful social work and even patient navigation systems to get patients in and out, and all kinds of imaging. We built a center called the Moakley Cancer Center, so that patients didn't have to go from the 3rd floor. We live on the East Coast, right? So that's the 3rd floor of this building to the 5th floor of that building to the 8th floor of another building 4 blocks away. Instead, it's all in one building. So patients can go to chemotherapy, radiation therapy, surgery, imaging can be in one building instead of sending people on a wild goose chase. So I want you to keep this slide. If you remember nothing else, think about this slide when you hear the talks over the next few days. And think about maybe the whole in that talk. Do they address all these things? We think about patients from top to bottom. Prevention of cancer, detection of cancer, diagnosis, how you're going to treat them, and then going on to the future, palliative care and survivorship. Last year, we talked very briefly about survivorship. I've invited Jennifer Hughes to come and talk about palliative care, because it's an important thing for you to know about. Cancer care doesn't end when you can't do anything further for the patient. You can do something for the patient until the day they die, and you can do something for their families. So it's important to remember that it's all together. It's another way of thinking about cancer care. What's the patient's ethnicity, gender, social history, family history? What's their insurance status? Here in Massachusetts, right, we have universal coverage. That's not the case in New York. When I was a resident, I was rotating out at a hospital on Long Island, and who should come in the door to our free care clinic but the guy who ran the deli next door to us. Well, he didn't have any cancer care. 2 kids, who by the way were going to Cornell and NYU, that he was putting through school. He was a heavy smoker. He had been coughing. They did a chest x-ray, found a good-sized lung tumor, which, by the way, had no nodal spread. We did a lobectomy, and he's, as far as I know, he's alive a number of years later. Found an early-stage lung cancer. Now, we had no insurance coverage in New York at the time, so how could we get him through? It would have been tens of thousands of dollars for him to get cancer care. So He, in fact, came through the emergency room with a cough. We admitted him because you don't have the right to refuse. Got him surgery. He's alive and productive years and years later. I personally consider that to be a triumph. On the other hand, we've paid the burden for that person to get chemotherapy. So when you think about your latest nanomedicine, nanoparticle, fancy viral delivery doodad, whatever it is you're working on, think about what the cost is, not only to the patient, but as a burden to society. How are you better or more efficient or better targeted? What makes you better than the other treatments, and not just in terms of being able to cure more? Because the other thing you're going to learn, if you haven't already learned, there's a risk-benefit to everything. There's an ROC curve to everything. You can't have a completely non-toxic, fully targeted agent. If you did, please let me know your name at the end, because I'm going to invest in you. Does that sound negative? I don't mean to be negative. I really love what I do. And everyone who's going to be speaking, they love what they do too. I know everyone who's going to be talking to you. I've invited them to come. I know what they're like as clinicians. They're wonderful clinicians. I would trust my family with them. I've sent some of my family to them. These are people who live cancer care. They live treating patients. And you really, I hope, will get a feeling for that. So this is another way of thinking about it, the political determinants of healthcare. What's going to be covered, what's not going to be covered. We're going to talk a little bit about robotic surgery, for example. We're going to talk about what the benefits of doing, very advanced surgical intervention is. One of our radiation oncologists, Greg Russo, is going to talk with you about some very fancy technology they have that's very precise for treatment, and about maybe the cost and efficacy of that. The other thing I'd really like you to leave with is to know the most durable cure is complete surgical resection for solid organ tumors. I know that if I do a good operation, you're going to have a better benefit from it. So I want to select who's going to do well. I want to do the best operation possible. The other thing you should know is that in the United States, most advanced surgery for things like pancreas cancer, thyroid cancer, liver cancer, and a couple others, is still done by people who do fewer than 3 to 5 of those operations per year. Okay? Now, I don't know about you, but when I was learning how to do RT-PCR, my first 3 or 5 plates, they were crap, right? I mean, I didn't know how to pipette. My curves were like 50% off. I mean, it was terrible. I have been in the lab, so I do know how to do some of this. So I learned, right? We all learn with time how to do things better. Well, then why is it that in the United States you still can have major surgery on a major organ when those people don't do all that many of them? Well, it's because if you live in, I don't mean to insult anybody, I don't know, Kalamazoo, Michigan, Juneau, Alaska, and you're a good distance away from a center, or maybe you don't have coverage for your health care, well, you're going to get health care right where you are. You're going to get your surgery right where you are. Maybe you're 89 and you don't want to travel to get your breast cancer taken care of. How did you find a breast cancer in an 89-year-old anyway? Should we be doing mammograms in the 89-year-old patients? What's the efficacy of that? What's the cost efficiency of that? So I know I have the good benefit of living in a city where, throw a stone, you'll find a good thyroid surgical oncologist, but that's not the case in the rest of the United States. Even pediatric thyroid surgery, the majority of it is done by people who are trained to do pediatric surgery, but the disease is very different in children than it is in adults. We also know that surgery is the oldest treatment for cancer. We have a central role in coordinating care. I am not just a technician. And if you have the good benefit to be in a program where you actually can come and go to multidisciplinary grand rounds or hear about how cancer care is given, we have multidisciplinary rounds where everyone sits down at the table to talk about how we take care of patients. So the history of surgical oncology is ancient. We even know from the Edwin Smith papyrus I had mentioned that we've been treating breast cancer, and there's been breast cancer for a very long time. In the 1800s, Dr. McDowell actually has a series of 13 patients that he removed an ovarian tumor from, and one of those patients lived for 30 years. Think about it. We had no good forms of antisepsis. We really didn't have much in the way of anesthesia, if any of you know about ship-side medicine. So he operated on 13 patients for ovarian tumors, which I think is fascinating. One of the oldest surgical interventions that I know of actually is for kidney stones. So to me, these are the two pivotal things that happen for surgical oncology. People ask me all the time what I consider to be the most important discovery for human health. So any ideas in the crowd what you think is the most important discovery? Raise your hand or say it. Yes? Antibiotics. Okay, I like that answer. Anyone else? Anesthesia. Well, okay, you're reading my slide. Yes, Joyce. Sanitation. So I think antibiotics are incredibly important. I think separation of clean from dirty water is even more important. Yes. Even the Romans knew that. They separated the dirty from the clean water in their bath. Mario, as you should know. Yes. Thank you to your countrymen for that contribution. But in terms of being able to surgically intervene in patients, anesthesia and antisepsis, absolutely crucial. I don't know how many of you know, but Dr. Semmelweis, who came up with the idea of how exactly women were dying of puerperal fever. It used to be you had this big dirty gown and you go from woman to woman. It's very, interventive, and you have blood on the front of your gown, and you go and you intervene and you deliver babies, and they die, and the women die from puerperal fever. Well, Dr. Semmelweis ran his own maternity ward. He separated his maternity ward off, and they practiced strict antisepsis. Any of you read the book Microbe Hunters? Thank you, Mom, by the way. My mom's in the audience. Wonderful book, Microbe Hunters. I don't read fiction anymore because nonfiction is just way too interesting. There's Dr. Semmelweis ran his own maternity ward, and they practiced strict antisepsis, washed their hands, new clothes, and the incidence of maternal puerperal fever dropped almost to nothing. He died insane because nobody would believe in him. Terrible tragedy. Think about that next time you think you have a great idea for treating cancer and nobody believes you. Dr. Semmelweis should not be your example. So modern surgical oncology has come a long way since then. So surgical techniques were refined. The concept of en bloc resection by Dr. Halstead, who in fact also invented the idea of the surgical gloves because his nurse, who was also, by the way, his girlfriend, didn't like to wash her hands in carbolic acid, gave her a terrible rash. Dr. Coker and Dr. Cushing, who in fact came up with the idea of residency programs to train you in how to do surgery. Before, there were barber surgeons and there were doctors. Any of you from England originally or come through? So surgeons are called, you're called doctor, but it's in fact an insult, right? Physicians are called Mr. So barber surgeons were considered very different from physicians. Dr. Bernie Fisher started one of the most important things for me, which is a clinical trials, national clinical trials training program, the NSABP, and they've been collecting tissue ever since in their repository in Pittsburgh, and that's where something called the Oncotype DX came from, if you're interested in genomic models. And many things have come since then. Automatic staplers by the Russians, the concept of endoscopic surgery. I worked with Dr. Shinya, who was one of the first people doing colonoscopy with Bill Wolfe. Transplantation. How about the fact that you can take an organ out of somebody's body and put it in somebody else's body? That's amazing to me. Transfusions. With each war, in fact, we've gotten better at treating different things. With one of the first world wars and the Civil War, we learned how to tie off arteries and veins and do it very cleanly. Then came the idea of pulmonary support, lung support, antisepsis, blood transfusion. We're trying to move away now from blood transfusion. And better risk assessment in patients. We have a central role as a surgeon in treating cancer. From all the things I showed you, prevention, diagnosis, treatment, palliation, survivorship, I initiate conversations with my patients early about advanced directives. Have you talked with your family about your wishes? How many in this room have DNR or discussed their end-of-life wishes with their family? By the end of this, I want to see 100% of you. You should have a conversation with your family about what you want your wishes to be. Because this kind of conversation you don't want to have happen at the end, trust me. I think it's a good thing. It tells you about how you want to be treated. And it's an understanding, it's a respect for life. It's a respect for the wishes of others. It's something that I consider to be one of the most noble arts, and that's why I'm really looking forward to hearing Jennifer Hughes' talk. So we could go through a patient visit and talk about this, but much more so I want to get to talking about what it is I actually do. So we're going to skip through this a little bit. We're going to talk about thyroid cancer. Okay. So raise your hands if you yourself have had cancer, a family member has cancer, or a close friend. Okay. Let's do the opposite. Raise your hand if nobody you know close to you, family member, has ever had cancer or been affected by it. Just a few. Okay. I'm not going to single you out, but I'm going to point out to you, almost everyone in this room has been affected by it in some form, right? Now, we all have to die from something, right? Any of you in here planning on living forever? Again, if you have that anti-aging potion, if it's got, I don't know, like cloudberry in it, or vitamin C, or so, let me know, because I will invest in your company if you have the cure for long. But chances are pretty good you're all going to die. And why do I say that? I say that because you want your life, I want my life, to be as long-lived and healthy and fruitful and productive as possible, right? I personally believe you get one go-round. I'm going to enjoy it as much as I possibly can. And I mean that for my patients as well. I want them to have one good go-round. I want them to have healthy, long lives. But I can't cure death. I can't keep people from dying at some point in their lives. I have to think, when I'm intervening in a patient, am I prolonging their life? Necessarily, unnecessarily? Is what I'm doing going to have an effect and a benefit that is worth the cost of the intervention? Now, I happen to have chosen thyroid cancer. 99.8% of my patients survive. I might have chosen that for a reason. But there are other challenges within how to treat thyroid cancer patients. But the majority of my patients are going to have a long, healthy life. So I am the kind of person who believes that you should not point to the body part you're talking about. People do that all the time. Breast surgeons, I know where your breast is. You really don't have to point to it. But in this case, I'm going to make an example. So I want you all to feel right in the middle, your voice box. And then you're going to put your 2 fingers there, and you're going to put your thumbs out. There's a muscle there. Keep running your fingers down until you feel a little thing, little lump. Makes you a little nauseous when you press on it. That's your thyroid gland. You can't live without that organ. You can't live, okay? You'll go into myxedema coma, as some of my early surgical predecessors found, if I remove every little bit of your thyroid gland, okay? So you may imagine it's got a rich blood supply, and it holds on like you can't imagine to your throat. Doesn't want to get removed, doesn't like to get removed. So surgery for it is very delicate surgery. Thyroid cancer care is the perfect example of multidisciplinary care. We're all involved with the care of patients from the very beginning. We have endocrinologists. Here we're fortunate to have 3 people devoted to just thyroid endocrinology. We have thyroid oncologists. We are fortunate to have one here, very well-known, Marsha Brose, down at University of Pennsylvania, runs clinical trials. We have all kinds of supportive services, voice therapy, radiologists for imaging. We're fortunate here that we've got quite a few people that we are interacting with for all kinds of biomedical engineering, new tools. I'm going to talk with you about some of those. Pathologists who are experts in reading thyroid pathology. It's not just in the larger batch of what they do. And of course, we have excellent thyroid surgeons here. Fortunately, we have 3 of them here. And I've told you the thyroid has a very rich anatomy. So the arteries, the veins, many of them, it likes to hold on to your neck, right? And most of my patients are going to do perfectly fine. They'll require thyroid hormone replacement for life after surgery, but every operation has the potential for complications. Now, I've asked our speakers to highlight problems, deficiencies, things we don't do well in care, because those are opportunities. Those are opportunities for us to think about how we could do better, how we could treat patients better, how we could be more selective in our care. Okay? Bleeding. Always potential for bleeding. I have 5 or 6 different ways to stop that bleeding. I've got a tool that costs $425, and then I've got ties that cost about 50 cents each. Why would I use the tool that costs $400 versus the tie that costs 50 cents? Well, maybe I'm doing it through a tiny little porthole, 5 millimeters, and I want to be able to do my surgery through that instead of a full incision. Or robotic surgery where I make an incision under the arm or through the nipple and go up so you don't have any scar on your neck at all. Well, then I want the $400 piece of equipment because it's long and thin and it replaces my finger better. We have the potential for voice changes from injury to the nerves. If you're interested in this, there's a very interesting center in town where they've developed all the tools for voice repair. If you've heard of, many of the singers come here to get their vocal cords operated on. He has patients sing themselves to sleep. They have great videos. They're singing, and then all of a sudden they're out with anesthesia. And then, much more interesting to me, he shows you what the vocal cords look like and how he intervenes on them. Fascinating. So I cut your nerve, you're hoarse. I cut both your nerves. You need a tube permanently to breathe. I pull your nerve a little bit too much. You could be permanently hoarse. I cut your upper nerves, then you're no longer a singer in your church choir, not at least as a soprano. So wouldn't it make sense? You want to go to somebody who knows where the nerves are, who understands the anatomy, who's very careful with them, maybe uses a nerve monitor, although we could talk about that, for example. I'll be on a panel at the American Thyroid Association this fall arguing about nerve integrity monitoring. In fact, it's a wonderful tool for my coronary arteries, but it does nothing for your vocal cords, because large randomized trials have not shown that there's benefit to nerve integrity monitoring at the time of surgery. So why use it? And yet almost everyone I know does. Low calcium. So you're going to hear a little bit about some of the surgery that I do, but one of the complications is I remove these 4 tiny little glands the size of a piece of rice called the parathyroid glands. They have nothing to do with the thyroid gland. They just live right there, and they love to cling tight. And in fact, we now know if your vitamin D level is low, they really don't like being touched. I push them out of the way and try and leave them behind. But sometimes they don't work well after being pushed aside. And you've got permanently low calcium, and that permanently low calcium is not a very good thing for you. You need to take many, many, many calcium pills through the day, and you can still have tremors, and in fact, you can develop some pretty bad complications from that. Another example of why I really need to know what I'm doing when I operate on you. But we have no substitute for parathyroid hormone. My new chairman, who will be stopping by at some point, Jerry Doherty, is an expert in parathyroid gland preservation and has a research lab devoted to trying to regrow parathyroids. The hormone that they release only lasts for 3 minutes in your blood system. So if you know something about this area, how do you get sustained release of something that needs to be at a very tiny level, needs to be incredibly precise? And by the way, there's only maybe a handful of people in the United States every year who need this. So where's the funding going to come from until somebody in Congress has a mother who has thyroid surgery and really needs to do something about the hypoparathyroidism? And there's complications from anesthesia. That's actually a very interesting area that we're going to get to if any of you know Atul Gawande's work, who is an endocrine surgeon here in Boston. Tough to have competition like Atul Gawande, but fortunately he's off writing books much of the time. The recurrent laryngeal nerve, absolutely fascinating. If you're interested in biomechanics, this is the perfect example of something that has very precise motion and is absolutely critical to something we consider to be important, our voice. So in fact, we have 2 nerves that go down. One of them loops around your aorta and the other comes back. So it's a very long nerve that doesn't like to be moved at all. And in fact, it breaks off and it innervates your vocal cords, technically the muscles that move your vocal cords. So when I cut one, there's unopposed action on the opposite side, and your cord gets kind of floppy right in the middle. Well, that's a problem, because if you know anything about nerve regrowth, it's like 1 millimeter per month or something like that. You're not going to get regrowth, or you're not going to get the same type of innervation back again. And this applies to many things in the body, so in terms of nerve injury, sural nerve injury, facial nerve injury, those sort of things. Fascinating area to think about for new products. We've tried collagen injections, gold weights, all kinds of things to make your vocal cords work properly again. And then, of course, you've got your superior branch, very tiny, dives in fast. We know that we don't look for it, because if we look for it, we can cause trauma to it. And it's innervated by a tiny, tiny little thread called the superior laryngeal nerve. That will make it so you're no longer a singer in your choir. So this is another area to think about. How do I reduce complications from thyroid surgery? Well, I make sure I'm ready before I go to the operating room. I have a checklist, so that's Atul Gawande's contribution, is going through the list. We go through every single thing. We go, tables locked, belts in place. My name is Dr. Rosen. We're here to do a thyroid operation. It's a total thyroid, so no sides to that. Make sure I don't take your left leg off when your right leg should have come off. And these are not jokes. These come for reasons, right? Antibiotics are correct, patient's allergies. We go through a whole checklist 4 times during surgery. Nerve monitoring, as I told you before, it's an excellent tool for my coronary arteries, but doesn't have proven benefit for your vocal cords. The way I say it is, don't you want me to feel comfortable when I'm doing your operation? Yes, you want me comfortable when I'm doing my operation. You want to preserve those parathyroid glands, and most importantly, you want to find a surgeon who's experienced in doing this. Now, if any of you have tried to find a physician for yourself for any particular reason, and you go online to Health Grades or any of the rating things, those are not very reliable sources for information on who's going to be a good doctor for you. Right? So maybe someone in this audience who's interested in computer databases or other kinds of things can come up with a better algorithm for finding, we can do Match.com, why can't we do physicianmatch.com to find someone who's going to be not going to bother you about your weight, but will really get on your mother's back about not annoying you about smoking or something like that. So this is a classic patient who walks into my office, a 40-year-old woman, asymmetric bulge in her thyroid area on routine physical exam. Okay. Thyroid nodules are incredibly common. Probably 4% of Americans have a thyroid nodule. But thyroid cancer is very uncommon. So most of those nodules are going to be benign and don't need to have surgery. How do we figure out who does and doesn't need surgical intervention and whether it's going to benefit them or not? We're finding the same thing I think I had mentioned in prostate. There are lots of nodules, PSA goes all over the place. We're not entirely sure who should get surgery, who should get radiation, who should get nothing at all. Same thing in lung. When I was a resident in New York City in the 1990s, you could get a full-body CT scan for $299.95 at one of the major hospitals up the street. Oh, that's great. You can find everything early. Except the problem was we found a lot of things, and then we didn't know what to do with them. So people were getting wedge resections of their lungs or all kinds of things, and we didn't really understand what we were doing. So early diagnosis or finding things early, you're going to find things. The more tests you do, the more things you're going to find, the less we necessarily know whether you should be intervening and doing those or not. So the answer to that, of course, in my mind is clinical trials. You should have clinical trials to see whether you need to intervene or not. When a patient comes in my office, I ask them about their family history. But I don't say, do you have a family history of Cowden's disease, or do you have a family history of MEN? Some people know that. What I say is, anybody in your family have a lump in their thyroid, a lump in their pancreas, a lump in their brain? Why does it matter? Because there's an association. There's an association between other diseases, which will kill you if I put you asleep under anesthesia without knowing about them. Okay? This is why you need to go to somebody who understands that it doesn't just exist. It's not just your thyroid nodule. It's all of you and your history and your family history. So I'm going to check a hormone level. I'm going to do a needle biopsy, and I am not going to do a radioactive iodine scan. Well, we used to do them all the time. Why don't we do them anymore? Now we know there's a phenomenon called stunning. I give you a little bit of radioactive iodine for the scan to see whether you've got a hot or cold nodule, and your thyroid gland is stunned. And then when it's time for me to treat you for your thyroid cancer, it doesn't want to take up radioactive iodine. And it was an unnecessary test. All I need is a TSH. All I need is one blood test to tell me if your thyroid's over or underactive. I don't need to get fancy, expensive scans. So fancy and expensive is not necessarily better. Cheap is not necessarily better either. You need to find the perfect blend for whatever it is, your test, your therapy, your intervention. So when I biopsy somebody's thyroid gland, it comes back as you got enough cells or you didn't. Hopefully I did it under ultrasound, and then I know that I got into the solid portion of it, so I don't just blindly biopsy something. Do it under ultrasound. I've got experience. I get it into the solid portion. Sometimes I don't get enough cells still. Still, 20% of the time, 1 out of 5 people, we do not get a diagnosis. We have enough cells, but they're not quite abnormal enough for us to tell. We make our decisions about what nodules to fine needle aspirate biopsy, lots of red blood cells, improve the technology to get rid of those. So why isn't it 100%? We've tried CT scans, PET scans, genetic markers, all kinds of things. Why isn't it 100%? Well, we don't know. But those patients need to have surgery for the purpose of diagnosis alone. Now, that's not an unnecessary surgery. That's surgery for the purpose of diagnosis. Only about 1/3 of them will turn out to have cancer. So 2/3 I could have avoided operating on, and 1/3 I could operate on and be better prepared because I know, in fact, that they have a cancer. Okay? So we're working on all kinds of things to try and improve that. One of those I'm going to tell you about, and the second one we're going to briefly mention. Thyroid surgery has a long history of innovation. For some reason, the history of surgical oncology is inextricably linked with thyroid. We started with Dr. Coker, who recognized antisepsis, also recognized it's a bad idea to remove all of the thyroid gland when we didn't have good thyroid hormone replacement. Now we do. Dr. Billroth was a wonderful teacher. It's important because, after all, after me comes what? People I've taught. Somebody's going to have to take my thyroid out. I can't take my own thyroid gland out. He also had a huge volume of patients, so that tells you, again, more you do, better you are at something. And Dr. Halstead, because he understood controlling the arteries, the blood vessels, and he wrote a book so that people didn't have to come and train with just him. All of these are important components to making sure there's a future for this sort of thing. And those of us in the room who are teachers or want to be teachers someday, this is your responsibility. Being a good teacher is very hard, actually. Even to the point where now we've tried doing robotic surgery to avoid incisions in the neck, although this has an FDA hold on it at the time. We could talk about why that's the case. So I worked on a project here. I was interested in this question. So I worked on a project with Irving Biggio using a technology called elastic scattering spectroscopy. Very simple. It's like a flashlight in the dark. What bounces back to your eyes is what you see. Cancer bounces things off differently than normal tissue. Those are the old school probes, and we actually used those in our first round, and we've developed a very small probe to go along with this. One of my colleagues is here in the audience. And the idea is it performs an optical biopsy without altering the tissue. Okay? Pathologists see different organelles in the different cells. Well, the ESS seems the same thing. If your cancer cell has more mitochondria, or thicker walls, or tighter packed, or something, that's going to bounce light off differently than normal tissue. So all those white particles look the same to you, but they look very different to the technology. And so we did it first ex vivo and now in vivo, ex vivo outside the body after thyroid surgery. Now, if any of you do mRNA profiling or that sort of thing, that tissue sits on the back table for a day or so, and you finally get it, and you can talk about the mRNA pattern. But when you have a thyroid surgeon participate with you in a clinical trial, probably go back. That tissue, the minute it's out of the neck, my fellow is there, picks it up, brings it to the back lab, sections it. You know, can't be any faster than if I put it right in the neck. We've made this into a needle probe that actually goes into the neck at the time of you getting your biopsy during ultrasound now. We've enrolled, actually it's now I think 60 patients in this, and we're working on building a discriminating pattern between the two, between benign and cancer. I love showing this slide because it's shows you the surgical absence of the thyroid gland. So I love that project. It's the perfect mix between endocrinology, pathology, biomedical engineering, and the surgeon, because I have the opportunity to intervene in those patients. We're also working with Kathy Klaprich on making a high-throughput gene chip, so I can tell you with a greater degree of certainty, hopefully very quickly, whether that's a malignancy or not. And this is what we call a platform technology, right? You could interchange various things, but the concept is there to improve diagnosis. So I said to you before, thyroid cancer is common, but not that common. Relatively few deaths. We generally know who's going to die from it fairly early on. So the most important thing for me is really, I'm going to skip through some of this, is to figure out who needs to have surgery and who doesn't. There's one last slide that I want to get to before I pass it on to my chemotherapy. So many good things to talk about here. Gene testing. Medullary thyroid cancer is a perfect example of this. It's a RET proto-oncogene. So we know it's autosomal dominant, which means if I've got it and you get the gene, you're going to get the disease. But we don't know what degree you're going to get that disease until we started doing gene testing. We realized that there were generally a couple of specific codons in a specific gene that are related to cancer, and we did large studies, and we found, in fact, based on that codon mutation, we can determine in therapy for you Perfect blend between technology and surgical intervention. So we get asked about genetic mutations in thyroid all the time. The hot one right now is BRAF. Very interesting. We have no idea what it means or does. We see it in benign nodules, in cancer. Maybe it's associated with more malignant disease. Maybe we should intervene more. Maybe it's in the lymph nodes. Maybe that makes a difference. We just know it's there and it's abnormal, but we don't have any idea what to do about it just yet. And it's not always abnormal, so it's not 100% of the time. I just came from the American Association of Endocrine Surgeons. I'm on the program committee there, and I can tell you we selected a lot of competing data to discuss what the use of this BRAF is. So these are the most common questions I get when I treat patients. I'm fortunate because thyroid cancer, now I should tell you I do endocrine surgery, so it's thyroid, parathyroid, adrenal, and pancreas. I chose to talk with you about the thyroid work today because it's something that more people I think would relate to. These are the questions that I get from patients when I'm treating things generally other than thyroid. What are my chances? Can you get it all? Did you get it all? Am I going to die from this? Will I be able to work during the therapy? Lots of people go to work during therapy. Lots of people have to go to work during therapy. Why did this happen to me? What did I do to make this happen? And the last one is, what can I do to keep it from coming back? So when I go in to talk with you about the surgical complications and whether you need surgery and why you need surgery and whether you're going to go on to live a healthy, productive life, I'm fortunate in thyroid cancer I can give you a lot of good responses. That's not the case for everything. So over the next couple of days, I'm going to encourage you to think about these questions, think about the problems people are presenting you with, think of it as an opportunity for something that you can design or do better, no matter what background you come from, and ask lots of questions. Okay. Thank you.